Tinea pedis is a contagious fungal infection affecting the skin of the feet. It is commonly referred to as athlete's foot due to its common presence in both athletes or people actively involved in physical activity. The fungi that is largely responsible for the contraction of Tinea pedis belongs to the group commonly referred to as dermatophytes. Now there are three genera of dermatophytes. These are Tritophyton, Microsporum, and Epidermophyton species. Now the dermatic fungus Tritophyton rubrum has been recognized as the most common cause of Tinea pedis, accounting for approximately 67% of all Tinea pedis infections. Tinea pedis is divided into three clinical forms that contain different signs and symptoms. These clinical forms include interdigital, moccasin, and vesiculobullous Tinea pedis. Interdigital Tinea pedis is the most prevalent type of athlete's foot and is typically found between the 4th and 5th digits. Patients with interdigital Tinea pedis often identify with symptoms such as dry or cracking skin, complaints of unpleasant odour, as well as an itching and burning sensation. The moccasin Tinea pedis is considered to be the most severe and prolonged type, which is mostly found on the bottom and lateral aspects of the feet. Symptoms include inflammation of the skin where the infection is present, a dry scale cracking appearance, and hyperkeratosis. Lastly, vesiculobullous Tinea pedis is the least common type of growth, and the symptoms include the development of vesicles or pustules on the sole of the feet.
The term diagnosis refers to the identification of a condition by examination of the patient's signs and symptoms, a systematic analysis of the patient's background history, evaluating test and research results, and the investigation of the assumed or probable causes. There are numerous ways that Tinea pedis can be distinguished and diagnosed. A health practitioner may diagnose Tinea pedis simply with the clinical appearance, which is the signs and symptoms that a patient presents with. However, in some circumstances, this method can be challenging and extremely unreliable. To improve the reliability, health practitioners may use a more accurate method, such as the skin lesion potassium hydroxide exam, which is viewed as the most common test for Tinea pedis. With the skin lesion potassium exam, a practitioner will scrape a small sample of infected skin and place it in potassium hydroxide, thus destroying the individual's healthy skin cells, leaving only fungal skin cells present. After microscopic examination, if fungal cells are present, the health practitioner will commence treatment for Tinea pedis. Another routine test for athlete's foot is the use of a dermophyte test media, which is also referred to as DTM. This form of specialized agar contains cyclohexamide, antibiotics, and phenol red pH indicators, which is used to inhibit dermophytes. The production of alkali from the dermophyte results in the agar turns the color from yellow to red, allowing the presence of the fungi to be identified and then treated.
The clinical course for Tinea pedis is that first the podiatrist needs to diagnose the condition to confirm that it is Tinea pedis. Next, the podiatrist will need to prescribe a treatment to the patient, and finally, a prognosis is needed to be identified. In order to diagnose the Tinea pedis, a podiatrist can either identify the Tinea pedis on the foot through identifying symptoms. If the podiatrist cannot confirm the condition by the symptoms straight up, then they will need to order for skin tests. Following the diagnosis process, the podiatrist will then provide a source of treatment to the patient. This is commonly an antifungal cream or potentially even some oral medication. Generally, these medications are only required to be taken for up to 2 weeks before completely overcoming the condition. If the bacteria comes into any complications, this will prolong the treatment, and a different method of treatment may be needed to be enforced, as the patient may be allergic to the bacteria. Also, if the patient is having the condition reoccur, then it is highly encouraged that the patient changes their methods of foot care to try avoid the conditions occurring again.
To begin treatment, patients are advised to wear clothing made of cotton or similar materials so to absorb moisture away from the skin, making the metaphytes less likely to grow. Barefoot, walking, and sharing footwear should also be discouraged to prevent reinfection or passing on the fungus or fungi. This is due to the possible presence of the dermatophytes in areas like a pool or a pet bed. There are two main types of antifungal therapies available for the treatment of Tinea Pedis. The first one of these being topical antifungal treatments. Topical treatments are usually in the form of creams or gels, which are applied directly to the skin to treat the fungal infection. Usually, topical treatments are stated to need 4 weeks of treatment to clear up the symptoms, but only 1 in the case of interdigital Tinea Pedis. The second primary form of treatment is systemic treatment, usually done through oral route and is normally undertaken when topical treatment proves unavailable to solve the problem or if the patient is intolerant to the topical drugs due to allergy. Treatment here takes around 2 to 4 weeks. It is extremely important in the issue to not immediately half-treat once symptoms have cleared and to continue using either the topical or systemic treatment for up to 2 weeks after the fact to ensure that there is a minimal chance of reinfection from fungus present on the sections of the feet. In general, treatments should aim to have a shorter onset of effect to reduce the development of resistance and to avoid the complications of having the tinea progress into its chronic form. Topical medications combined with systemic treatment, as described by Sahu, is expected to have greater mycological clearance than either form alone whilst increasing the coverage of treatment.